Hi, today we're talking about the business of medicine. There is a reflection at the end of this screencast, so consider reflecting upon what we talk about as it corresponds with this unit. One of the course objectives for this unit is to explain and identify ways in which physician assistants fulfill their roles and responsibilities to the healthcare system. With that in mind, take a moment to think about how the medical industry would be impacted if the PA profession was discontinued. Who would be affected? What would the workload be like? What financial implications would there be? How would patients be impacted? Let's walk through some of the ways PAs impact how medicine is performed and administered in the United States. So what are the benefits physician assistants offer the healthcare system? Obviously, the role of a PA is not meant to replace physicians, but to extend patient care and efficiency and improve outcomes. And one of the most obvious advantages PAs offer is that they are trained quickly at a lower cost and can start contributing to the workforce earlier. In the article, The Case for the Physician Assistant, the Royal College of Physicians in the UK suggests that PAs are valuable team players because they have the flexibility to fulfill different roles depending on the changing needs of the team. They can also serve as the glue of the team because they help link different professionals together, like doctors and nurses. The same group suggests that despite the advantages of specialization, sometimes broad medical perspectives are lost as a result. PAs are valuable in offering broader medical perspectives that other teammates may have forgotten. The Association of American Medical Colleges, or the AAMC, projects that there will be a shortage of between 40,000 and 105,000 physicians by 2030. In the article, How Adding Physician Assistants Improves Hospital Revenue Cycles, it is suggested that using more PAs can help optimize workflows. They also found that in a traditional staffing model, physicians saw 94% of patients, while physician assistants saw 36%. The same article suggests that PAs can help serve as flow managers by improving efficiency of the medical team. With physician assistants serving as workflow managers, doctors can complete more charts, refill more prescriptions, and respond to more patient phone calls in a shorter amount of time. Not only does it demonstrate more efficiency for the team, but can likely impact accuracy and patient satisfaction. The article also found that utilizing physician assistants also helped increase patient satisfaction rates and improve patient perception of access to appointments. One study suggested that most institutions should be able to hire 2 full-time physician assistants for the cost of 1 full-time physician. Consider the resulting impact on patient care and finances. Another case study found that shifting from a hospital care team of primarily physicians to one of equal physicians to physician assistants resulted in patient savings of between $550 and $2,200. Physician assistants assist in offering cost-effective health care and resource allocation that does not compromise quality of care. In a 2009 survey, the Medical Group Management Association found that PAs in family practice had 42% of ambulatory patient encounters compared to 58% by physicians. And according to an article in the Journal of Ethics, physician assistants in family medicine offer nearly equivalent relative value units which reflect personnel time and level of skill to physicians. They also suggest that PAs may not be getting adequate credit for the work they do because many encounters are coded as physician encounters. And building upon that concept, one study suggests that hiring a PA in a large family practice could offer the equivalent of between 73 to 96% of a full-time family practice physician. The National Center for Health Statistics found that PAs often delivered care in clinics associated with non-teaching hospitals and handled a higher percentage of Medicaid, CHIP, uninsured patients, and younger patients, and worked in more medically underserved communities and saw more preventative care visits than physicians. One physician and professor of medicine at Yale School of Medicine thinks the future of medicine will see PAs serving as the main providers for primary care. Do you think physician assistants and nurse practitioners will replace most family practice doctors? Why or why not? Another objective for this course today is to differentiate the various healthcare funding sources and payment systems that provide coverage for patient care in terms of types and categories of service coverage, requirements for reimbursement, patient eligibility, limitations, and becoming a participating provider. Let's start with Medicare. Medicare is a federal health insurance plan. In order to qualify for Medicare, a person must either have a disability, have end-stage renal disease, or most commonly, be over the age of 65 years old. Additionally, patients 65 and older may qualify for free Part A if they or their spouse worked and paid into Medicare for at least 10 years. Others may be eligible to pay for Part A. All participants of Part B must pay. Individuals may go to Medicare.gov to see what they're eligible for and to determine their premiums. The Centers for Medicare and Medicaid Services, or CMS.gov, can help answer your questions about Medicare and Medicaid and allow you to enroll as a provider. Providers may either become a participating provider, which means they must accept Medicare assignment for all Medicare-covered services, or they can choose to accept Medicare for limited services. One of the biggest limitations to Medicare is that reimbursement rates are often lower than those of private insurance. One Kaiser Family Foundation study found 93% of non-pediatric primary care physicians were participating providers in 2015, but only 72% took new Medicare patients. So how can physician assistants help be part of the solution, since they are already more cost-effective than physicians? According to the article, Medicare for All sounds good, but what does it mean? Medicare has other limitations, including lack of an out-of-pocket annual maximum, annual and lifetime limits for hospital coverage, and lack of access to vision, dental, and other benefits which may be only offered a la carte. Medicaid is a federal state program, which means it is a state-run program but governed by federal guidelines. That means Medicaid benefits may vary from state to state. Medicaid is an assistance program that serves low-income people and either provides benefits at no cost or with a small copay. This is designed for those who cannot afford insurance and cannot get it through their employer. Medicaid benefits may depend on the state, household size, and income. Patients may see if they qualify at healthcare.gov. If eligible, they must fill out an application for coverage. Because Medicaid is state managed, in order to become a Medicaid provider, you will have to apply and enroll according to the procedures for each individual state. One of the limitations of Medicaid is similar to Medicare in that reimbursement rates are often lower than private insurance rates. This can also limit care options and often significantly impact patient choice for long-term care facilities, as many high-quality nursing homes, etc., may limit the number of patients they accept on Medicaid. Medicaid payments often take longer to process, and because each state manages Medicaid differently, delivery can vary depending upon where a person lives. CHIP was created in 1997 to build upon Medicaid coverage for low-income children. States also govern CHIP but use federal funds to expand their Medicaid program or create a standalone program or a combination of both. The main goal of CHIP is to expand the reach of government-funded healthcare coverage to more low-income children. CHIP usually has a more simplified enrollment process, making it easier for children to obtain coverage. Although CHIP covers more children, its coverage options are often more limited than Medicaid. There are other public assistance programs, of course. Two other programs are home and community-based services, which help individuals with disabilities in their living situations, and children and youth with special health care needs, which helps families with children with disabilities that don't qualify for Medicaid but still have health insurance needs. HMOs, or health maintenance organizations, often offer lower monthly premiums because they can control their level of payments because they only use providers and facilities that have agreed to a certain level of payment. They often have lower copays and coinsurance. HMOs have a strong focus on primary care, as they usually require patients to coordinate their care through a primary care physician. This means a patient cannot visit a specialist without first seeing their primary care physician. Obviously, many patients are covered by third-party insurance coverage, often partially covered by their employer. The benefits to private health insurance often include greater choice, which can often result in better care. But it comes at a higher cost, and not all health insurance is created equal. Private insurance can also limit what they choose to pay for, and there can be confusion about what services are covered and not covered. So what are some of the benefits and limitations you have observed with these different funding sources? Caseworkers can be helpful resources for patients. According to the Case Management Society of America, case management is the process of assessing, planning, facilitating case coordination, and evaluating and advocating for options and services that meet the needs of the patient. When you are a provider, you may work with caseworkers to help advocate for patients and help them identify what their options are for care and services. That concludes today's lecture. Remember to complete the Business and Medicine Reflection homework.